Hello, everyone, and thank you for joining us today. Before we get started, I would like to ask you to refrain from recording any audio or video or taking screenshots during today's webinar. This presentation and the corresponding slides are copyrighted by Robson Forensic and may not be recorded, copied, distributed, or otherwise used without authorization. If you have questions throughout the presentation, you can submit them to us via the Q&A button at the bottom of your Zoom screen or via email at inquiries@robsonforensic.com. Today's presentation will be on investigating surgical errors by our own Dr. Rebekah Price. Rebekah, I will turn it over to you.
Hi, guys. It's nice to be here today. Thank you for taking time out of your busy schedules to listen to something that's very near and dear to my heart. I wanted to give you a little bit of background for some context. I obtained my Bachelor of Science degree from Mercer University in their nursing school and went for a Master's of Science in Nursing from Indiana State University, and finally got my Doctorate of Nursing Practice degree from Indiana State University. I am a board-certified family nurse practitioner and a registered nurse. I have held active licenses in several states nationwide. I have nearly 20 years of hands-on experience in many inpatient and outpatient environments, including emergency care, critical care, hospice, and palliative care. But since this webinar is focused on surgical errors, I'm going to highlight my experiences that pertain to surgery. I have worked as a surgical nurse nationwide, assisting large hospitals, outpatient surgical centers, and private practices with their surgical staffing needs. My diverse range of surgical experiences includes general surgery, neurosurgery, oral and maxillofacial surgery, orthopedic, cardiothoracic, plastic and reconstruction, gynecological, and colorectal surgeries, just to name a few. I have dedicated my life to global missions, medical missions, and I've worked in numerous countries across Asia, Africa, North and South America. And one of the highlights of my life has been serving on board the Mercy ship. It's a floating hospital on the west coast of Africa. And I was invited to go assist with hundreds of life-saving surgeries for children and adults who otherwise would have gone without. So having that global and national experience, my greatest passion in nursing is enhancing the quality of patient experiences and promoting safe practices. My extensive knowledge enables me to provide a high level of support to medical professionals, resulting in optimal patient outcomes. So what qualifies me as an expert in these kind of cases is not only have I worked in dozens of surgical facilities and settings, I have had an active role in all three of these surgical stages. There's preoperative, intraoperative, and postoperative stages. And I know and I understand these stages and what needs to occur in each phase. So when I take these surgical cases on, I take a methodical approach. And I look at the surgical inception to surgical completion and make sure every step has been executed in accordance with the standard of care. So we're going to talk about never events, but when we talk about standards, OSHA, the Joint Commission, Association of Perioperative Nurses, also called AORN, they all play a role in adopting and enforcing safety standards and evidence-based recommendations for safe perioperative patient care and workplace safety. So what are never events? When we use the word never event, you may have heard the term sentinel event. It's an unexpected occurrence involving severe physical and psychological injury or death. So these largely preventable events should never have occurred if the appropriate protocols are followed. These events trigger an immediate investigation by the organization, and they're publicly reportable. They require a review by the Joint Commission, which is the nation's oldest healthcare accreditation body that sets patient safety standards. So some of the top never events that happen in surgery are the wrong site, doing surgery on the wrong patient, doing the wrong procedure, and then having a retained foreign object inside a patient's body following a surgical procedure. These are just a few of never events, but we're going to just, I'm going to take you through some of the key players, and when we get a case like this, what can go wrong and how we approach this. So who are the key players? It really depends on the environment. Again, it could be a small private practice, has a very small team, up to a very large teaching hospital. But here are some of the key players that could be involved in a case. You have the surgeon, you could have consultant surgeons. So someone may need a hysterectomy and a bladder sling. So you may have urology and gynecology in the same surgery. So multiple surgeons, residents or med students, depending on if it's a teaching hospital. There could be physician assistants or nurse practitioners. They practice medicine under the supervision of a doctor, and they act as an assistant to the surgeon, and they'll close the incision with sutures or staples. You have your anesthesiologist team, so that includes the anesthesiologist as well as a nurse anesthetist, and they are keeping the patient's pain and level of consciousness safe for a successful surgery. You have your surgical techs. They are going to set up the sterile operating room, getting supplies and tools ready. You can have a medical device company representative. So if you have a surgery involving an artificial joint, pacemakers, spine stabilizers, they can assist with equipment sizing and functioning. So there's two types of nurses inside the operating room. We'll talk about the other ones on the other phases of the surgery. But inside the OR, you can have a scrub nurse. That's someone who is assisting the surgeon during the surgery by selecting and passing out instruments. There is a circulation nurse. She's managing the whole operating room and protecting the safety and the health needs of the patients by monitoring the activities and the members of the surgical team. You also have your preoperative nurses and your postoperative nurses. So this interdisciplinary team, it takes a lot of communication and teamwork, decision-making under pressure, situational awareness, and leadership. And there's a clear correlation between these case outcomes and how well the surgical team discusses key safety concerns, the critical stages of surgery, and the procedure's progress. So one of the biggest misconceptions is that most injuries happen right in the middle of the OR, and that is where most of the focus gets, I think. But I would really like to shed light on how surgery is broken down. So you have three phases. This is called the perioperative period, and that includes the preoperative phase, the intraoperative phase, and the postoperative phase. And the reason to have these different phases is to help differentiate tasks and establish clear responsibilities for delivering each phase of care. So it helps provide a clear chain of command, so hospital teams can deliver consistent, optimal care from when surgery is ordered to when the person is fully recovered. Maintaining strict adherence to procedures. There are checklists that are involved, and we'll talk more about that in just a second. So the preoperative phase, what happens? When a patient comes in for surgery, they walk in the hospital or the facility. The nurse's role in this preoperative stage is to identify patient-specific needs and risk factors by doing quality assessments. And knowing these patient-specific needs can affect the surgical experience and care trajectory. So it's a real important to gather all the information possible. So we're taking a thorough medical history. Has the patient had previous surgeries or anesthesia experience? Did they have difficulty with anesthesia? We will take an electrocardiogram, vital signs, looking at any pre-existing cardiovascular or respiratory issues that could affect their breathing. Documenting all medications, drug abuse, any allergies, mental and physiological status of the patient, their functional status. Are they able to have a good range of motion? It's so important to establish that baseline. Any skin conditions or risks for wounds, any underlying pain, anxiety, or risk factors that could show itself in the recovery room and cause a lot of issues. Nutritional status. How long has a patient been NPO or without food or drink? This is a huge one because if someone is eating or drinking something too close to the time of anesthesia, that can cause aspiration and can be very critical. And any sensory impairments, language barriers, cultural or spiritual needs are all considered in this phase. And the signing of the consent forms, this is an understated issue. There can be many surgeries that sound alike. And these are, it takes multiple verifications to make sure that the consent is right, according to what the patient understands, what the surgeon understands, and what is written on the consent form. So the difference between a A thoracentesis, a thoracoscopy can be very close in spelling, but very different procedures. So next you have the intraoperative phase. This is the period where the patient is on the operating table to when the operation has been completed and the wound is closed. The nursing responsibilities during this phase include assessing the patient's physiological and psychological status, promoting safety and privacy, preventing wound infections, and promoting healing. The universal protocol promoted by the Joint Commission has been effective about reducing surgical never events. So expert witness investigation into these incidents will often seek to understand the manner in which these 3 successive steps were implemented. And these are verbal checklists. So first you have your briefing. We ask before the induction of anesthesia, has the patient been identified using 2 unique identifiers? Who are the providers? What is the procedure site and side? And does it match the consent form? Does the patient have any drug or latex allergies? Does the patient have any difficult airway or aspiration risks? When was their last food and drink intake? Have they had problems with anesthesia before? Do they need anesthesia procedures before the incision? So do they need a central line? Do they need anesthesia blocks? Have they had these done, or do we anticipate needing to have this done before an anesthesia starts? Have all team members introduced themselves by name and role? This is critical because we work together as a team and we rely on the discernment from each other and speaking up. So having that introduction and acknowledgement of every person's name and role is very critical. And the second step in the universal protocol is the timeouts. This is right before the skin incision. It's where everyone stops and there's a verbal checklist. Is the correct patient? Is this the correct patient? Is this the correct procedure and the correct side? It is read verbatim from the consent form. Has the site been marked and is it visible? Is the safety strap on the patient on the operating table? Are images displayed and labeled? Is the patient placed in the correct position for the procedure? Have the safety concerns been addressed, like having the appropriate pre-antibiotic selected and started? Is there a DVT risk? Do they have normal body temperature? Is there any anticipated blood loss? What about implants and equipment needs? Are there any fire risks? Anytime you're using pure oxygen, there's the chance that could make anything instantly flammable. So these are the checklists that have to be done before the incision starts. And then finally, before the surgeon and patient leave the room, when the procedure is complete, there's a debriefing period. This is where everyone stops. The circulating nurse announced the results of the counts, the instruments, sponges, needles, making sure everything is accounted for. The circulating nurse confirms the exact procedure and diagnosis with the surgeon. So that then gets handed off to the recovery nurse and is documented appropriately. The circulating nurse confirms all specimens are accurately labeled. Were there any delays in the case? Any equipment or instruction malfunction that need to be taken care of before the next case? Are there any concerns for recovery and management of the patient or pain needing for additional anesthesia blocks, respiratory issues that could complicate extubating? So this is important to have these solidified before the transition to the final phase. So the final phase is the postoperative phase. Postoperative care promotes the client's recovery after surgery by managing pain, supporting oxygenation and cardiovascular stability, extubating and ensuring they can breathe on their own, maintaining fluid balance and maintaining body temperature, providing wound care, monitoring valve function, assisting with mobility, and preventing complications. So it's really easy to see this interdisciplinary nature of work in the surgical environment relies on cooperation upon every link of the surgical team chain. We work together in a collaborative effort to ensure patient safety and avoid errors. Surgery is undeniably one of the most complex industries. It requires a strict demand for technical proficiency, the urgency to process high volumes of information, dealing with patients' comorbidities, multiple comorbidities to think about. And so the surgery workers have to possess a unparalleled skill and expertise to deliver the best possible patient outcomes. So when I invest these surgical cases, I when I investigate, I apply my expertise to forensic casework involving the standard of care for nurses and the nursing staff regarding injuries, abuse, neglect, and compliance. I take a high-level look at each phase of the surgical process, and I make sure that some of the questions I'm asking myself are going to be, were the consent forms filled out thoroughly and adequately before surgery? Were patient-specific risks identified? Was the timeout performed adequately? Was there adequate staff-to-staff or staff-family communication during the handoffs and transition of care? Did the policies meet the standard of care? And was the nursing staff adequately trained? There's dozens of questions that I'm going to ask, but these are just a few that I will consider. But having that knowledge of every phase of the surgical care has really set me apart to be able to take these cases and look at the inception to completion and give it a good look and help. So if there's any questions you guys have, that I hope that helps highlight my experience and what the surgery process looks like. So when you have a case like this, please reach out, and I would love to walk through it with you. I'm going to turn this over to Anne.
Thank you so much, Rebekah. Again, if you have any questions, submit them to us through that Q&A button at the bottom of your screen. So far, let's see what we've got here. Who has the power / obligation to stop a surgery?
That is a great question. So the truth is anyone does. The World Health Organization has created a Speak Up campaign. It spreads responsibility to every member of the surgical team and gives them the power to question the process at any moment. So you could have one timeout, and if there's any question or any concern at any point at any time during the surgery, anyone in that surgical team can speak up and demand another timeout. And that is a really critical part to consider, is the communication piece, because there are so many roles and because there are so many phases of surgery. Things can get missed, information can be incomplete. And so that gives anyone the power and the responsibility to speak up.
Wow, okay. And now for the nurses, do surgical nurses require any specific credentials or education to be in the surgery?
Well, the answer is it depends. It depends state to state. State to state have different practice acts required for nurses. However, most nursing surgical facilities are going to require a registered nurse level. So an LPN most likely could not work in that surgical environment. So it's going to start with a registered bachelor's prepared registered nurse. Anyone can go, any registered nurse can work in surgery. There doesn't require additional education. There will be plenty of on-site training, and there are certifications that can be met, but not required to work in surgery care. It's just like working, I started off in emergency care and I had to get multiple certifications for that environment, but my degree and my education and training allowed me to go from emergency care to surgery care to then hospice and palliative care. So our education and training allows us to work in different sectors of the nursing field.
Wow. Learning new things every day. Okay, it looks like that's it for questions. Again, if you want to talk offline, if you have a case that you would like to discuss, shoot us an email at inquiries@robsonforensic.com so we can clear any conflicts before we talk. And you can always find us at robsonforensic.com. If you want to see Rebekah's CV, just go to robsonforensic.com/price and you'll find everything there. Thank you everybody for joining us, and we'll catch you on the next one.